Hi, my name is Terry Welch, and I'm the Administrative Assistant at the Northeastern Ontario Stroke Network. I am pleased to introduce our next speaker, Susan Bursey. Susan has been the Regional Director of the Northeastern Ontario Stroke Network since 2016, and prior to that, she was the network's Regional Education Coordinator for 8 years. Susan is from Sudbury and is a physiotherapist by background. Having started her career at Health Sciences North in 1994, immediately following her graduation from the University of Toronto. Welcome, Susan.
Thanks, Terry. This morning, I'll be providing you with an overview of the stroke system in Northeastern Ontario. At the end of this session, participants will be able to navigate the system of hyperacute and acute stroke care in Northeastern Ontario, and you can appreciate how and where you fit in within that system. You'll be able to describe examples for how a person with an acute stroke can access treatment. First off, I'll just explain the Northeastern Ontario Stroke Network. Our team includes a regional director, medical director, regional rehab coordinator, and education coordinator, Terry, who you just met as our administrative assistant. We have stroke nurses employed across the region in the network, as well as clinic clerks at our prevention clinics, and 3 district stroke coordinators. So we are a regional team working together to advance our stroke system. We implement best practices, we develop educational materials and resources and tools. We support the startup of new services or we expand existing services. We work on standardizing stroke prevention and care. We work with a variety of stroke care stakeholders, and we lead or support stroke care system planning, and we're engaged in valuation. The Stroke Network has been in existence since the early 2000s. Our mandate spans the whole northeast portion of the province, and we're one of 11 stroke regions in Ontario. We're funded by the Ministry of Health, and we're hosted by Health Sciences North in Sudbury. This is a look now at our stroke network's geography. It aligns nicely with the Northeast LHIN boundaries. It's a fairly large region, as you know, and it can appreciate with over 500,000 in a population. I've indicated on this map these red stars. The red stars indicate the locations of our 3 district stroke centers in our hub cities, if you will, in Timmins, the Sioux, and North Bay. And in Sudbury, I've denoted the regional stroke center, our one and only regional stroke center, which is Health Sciences North in Sudbury. This is just a zoomed in look. So I've taken away the Moose Factory and James Bay Coast section, but you can still appreciate here the 4 districts: Cochrane, Algoma, Sudbury Manitoulin, Parry Sound, and Nipissing-Temiskaming, and all the small communities that are located within each district. Here's another look at our districts as well. And this is a slide to let you know that there is a district stroke coordinator that works at each health hub center and is responsible for the stroke care system within their district. So Nicholas Noob, who you'll meet later, works at Timmins District Hospital. Lisa Tyven, you'll also meet later, and she works at Sioux Area Hospital. Christine Thompson will join us shortly, and she works at North Bay Regional Health Center. And I'm Susan, working at Health Sciences North and responsible for Sudbury Manitoulin and Parry Sound District in terms of the stroke system. So now we'll have a look at how someone in our region can access hyperacute stroke care if they happen to have a stroke. So one scenario where somebody can access treatment is what we call our bypass protocol. And here's an example. Mr. Jones had a stroke while watching his grandson play hockey at the local arena in Englehart. The concession stand worker called 911. So what helped Mr. Jones is that this was a witnessed stroke. So we know the onset time. The public that were around him recognized signs of stroke and knew what to do, to call 911. The paramedics that responded followed their directive for those within 0 to 6 hours of the onset of stroke, and therefore they bypassed the Englehart Community Hospital and redirected him to the nearest telestroke site which was Temiskaming Hospital in this case, for time-sensitive treatment. So just looking at this process map from left to right, this just suggests the path that Mr. Jones would follow. EMS, land ambulance, would bring him to the telestroke site. Once in the emergency department, he would be assessed for stroke signs, confirmed the time of onset of his stroke, sent for advanced imaging, especially for stroke, following a provincial protocol for CT-CTA. The physician there would engage in a telestroke consultation to receive advice from a practicing stroke neurologist in Ontario. He may qualify for IB thrombolysis for clot dissolving. And potentially through that consultation, it might be determined that he's an EVT candidate, and he could be transported for EVT via land ambulance or through air ambulance through Orange to an EVT center. And for the region, that is HSN. Another scenario where someone who sustains a stroke can access treatment is through what we call our walk-in protocol. Here's another example. Mr. Smith woke up with signs of a stroke at his home in North Bay, and his wife drove him to their hospital, which happened to be a district stroke center, North Bay Regional Health Center. Now, because Mrs. Smith drove him, there's no EMS, so there's no pre-alert to give a heads up to the ED that there's an incoming stroke protocol. So Mr. Smith is relying on the triage RN to screen him and to trigger an acute stroke protocol or a code stroke response in that ED. Now, North Bay Regional Health Center has already revised their walk-in protocol to reflect the new extended window to identify an acute stroke protocol up to 24 hours post-onset. And because he's a wake-up stroke, we don't know the onset time. And so he would be considered someone who's presenting in this so-called extended window. Now, the TPA window has closed, but he could be a possible candidate for mechanical thrombectomy or EVT. So again, on this side, on this screen, you'll see a process map going from left to right, where he is presenting to the triage nurse. He's being screened for stroke signs because it's greater than 6 hours from onset. He's being evaluated with an additional screen called the ACT FAST. If this proves to be positive and we're still thinking acute stroke protocol, he'll move on to have immediate scanning of his brain. North Bay uses telestroke for consultations and for late window patients as well. And if he's determined to be a candidate for EVT, he'd either use land or air to access EVT consideration at HSN. Now, I've mentioned telestroke a couple of times. So just to point out that the Northeast is a user of the telestroke program, and it is a service that supports our physicians in our region. So an example of telestroke is that a physician in a telestroke hospital anywhere in our Northeast of our locations is able to consult quite quickly with a stroke neurologist who's working in another city. For example, Ottawa, London, Toronto. Now, in addition to our designated stroke centers mentioned earlier, Sudbury Hospital, North Bay, Timmins, and Sudbury, we also have 4 telestroke referring sites, one in Hearst, Kapuskasing, Temiskaming, and Moose Factory. Now, those 4 sites are imaging equipped following the provincial CT-CTA protocol, and they're competent and able to deliver TPA medication. And telestroke is for hyperacute stroke treatment decision-making only in those first few hours post-onset of stroke. So if we look at our map again, and I've added now those 4 telestroke sites in green, you can appreciate how this has enabled better access to care and to time-sensitive treatment for patients living in our region. Another scenario where a person who's had a stroke can access treatment is through what we call the inpatient stroke protocol. And here's another example where Mrs. Maxwell, while still at HSN, woke up the day after her total knee replacement, unable to speak and exhibiting severe weakness. Her bedside nurse recognized these new signs and symptoms as a possible acute stroke. This RN triggered the hospital's inpatient stroke protocol. The MRP physician immediately involved HSN's on-call stroke physician. Now, while she's ineligible for TPA due to that recent surgery, she still can be considered for mechanical thrombectomy. And also, even though it's a wake-up stroke, there is an opportunity to consider her for removing that clot mechanically. So acute stroke treatment is certainly a time-sensitive opportunity here. Each of our treatments have a distinct window of opportunity. TPA is still 0 to 4.5 hours from stroke, and EVT is now up to 24 hours post-stroke in highly selected individuals. And both have a higher likelihood of a good outcome if they're done early. And so really, it means that teams must work together, work fast, and work efficiently. Another component of stroke care is having one's acute stroke care provided on a stroke unit. There is strong evidence that exists for reduced mortality and better outcomes if that care is provided on a stroke unit. We have 4 in our region. The picture on the right depicts and showcases the stroke team in the Sioux, who were proud to launch their stroke unit this past September. Now, on a stroke unit, stroke patients are cohorted. The care team of allied health and nurses participate in and complete additional training, some of which you'll hear about later today, such as dysphagia screening, neurological assessment, and other stroke care competencies. On each of our 4 stroke units in the region, we have produced these large visual roadmaps posted on the walls at these stroke units. And we did this in response to patients and families telling us that they weren't sure what existed for them to help their recovery once they left hospital. And so this provided them with a bit of a sense that there are still opportunities and some services that they can access to support the recovery even after they leave the hospital. And this visual roadmap is a conversation starter for one, via the nurse, the physician, allied health, the community stroke navigator, to support and answer questions about what might exist and what the path looks like going forward for them. Now, a portion of our patients and the people that have a stroke will be eligible and benefit from inpatient rehabilitation for approximately 4 to 6 weeks. We have designated inpatient rehab beds at our 4 hub hospitals, Timmins, North Bay, the Sioux, and Sudbury, as well as 5 designated rehab beds in West Parry Sound. An application process is in place, and one must be able to tolerate and participate in the active program and demonstrate a potential to learn and to improve functionally. Our region also has 4 stroke prevention clinics, the Sioux, Timmins, North Bay, and in Sudbury. And each of these stroke prevention clinics provides an evidence-based, high-quality service to the people of Northeastern Ontario with stroke or TIA, and ensures urgent access to medical management and expert care. The clinics ensure that immediate risk reduction measures are provided, like medication prescription, blood pressure control, lifestyle modifications, personalized education, etc. In many cases, we can prevent admission to hospital when imaging, tests, and intervention can be completed as an outpatient. We do recommend that all TIA patients discharged from our region's EDs be referred to one of the 4 clinics to be seen by a physician and a nurse with stroke expertise. All the regional stroke networks take direction from the provincial body called Core Health Ontario. It's an agency that recently joined Ontario Health. Using data and evidence, Core Health so-called leads the way, provides us that direction as they enhance cardiac, stroke, and vascular care in the province. They coordinate various meetings, council tables, and working groups, bringing together all 11 stroke regions to plan and work together to further develop quality stroke care for all Ontarians. Core Health has a website, and there's a lot of information on it and a lot of resources available. What I've chosen to highlight today is Core Competency Framework for Stroke. This is a robust framework to help one build their own personal core competencies if they're working in stroke care. A number of disciplines have been included in this core competency framework, and there is this complete section for nursing. If this is of interest to you and you have not completed your core competencies for stroke and nursing, or you're new to stroke or need a refresher, I would encourage you to visit this website or reach out to Sue Varelli, our Regional Education Coordinator, to learn more. Our Regional Stroke Network has our own website as well. When you go and visit our website, there's a number of tabs along the top. Here I'm showcasing the Education tab, and this is where we post upcoming educational opportunities, whether there are webinars, conferences, workshops, other skill-based courses that we host, organize, or help connect one to. And here's an example of one that happened with a physician who's well known in Vancouver. And this particular course was geared for occupational therapists, physiotherapists, and rehab assistants. Our website has a section that will link you to our new YouTube channel. And here we post previously recorded webinars and videos that might enhance your practice. And of note, today's webinars will be archived and posted to this YouTube channel as well for future viewing by nurses. Now I'm on the Education Fund tab, and I wanted everyone to realize that we have an opportunity to provide you with some funding should you wish to attend a stroke-related course that has a registration fee, or perhaps travel expenses related to attending it. And you must apply and be approved prior to receiving these funds. And we have up to $1,000 per applicant available. We also have a section on our website for resources. This is just a couple of examples here on the screen. One you may have already done or heard about, and it's a self-learning program for someone who's working in a stroke unit and requiring basic orientation. And this is hosted by the Southwestern Ontario Stroke Network, and it's free. We also have a number of posters that we have developed over the years on a variety of stroke care topics, and they might be useful for your unit, for your organization, for your colleagues, and as well as potentially for patients. I wanted to draw a distinction between us and Heart and Stroke. Certainly Heart and Stroke is a close working partner of ours, but they have a different mandate. Their mandate is strongly around public awareness and research funding. And as a charitable organization, they accept donations, as you know. But they also do host the Canadian Stroke Best Practice Recommendations on their website. So that's where that can support us as healthcare providers. And these best practice recommendations are updated on a regular basis. And this is our go-to site for knowing the latest in terms of evidence and practice that we all should be aiming and striving to achieve and implement. And we'll end on a reminder of the signs of stroke. Certainly, all of us being very well versed on what the signs of stroke are can help us recognize stroke in a loved one, in a colleague, or a stranger, someone in the public. And so the Heart and Stroke supports us promoting the FAST mnemonic wherever and whenever we can. And the last line is certainly true, that if we acting fast, because if we do so, the quicker we can provide care for that individual and access to treatment, the more of the person we'll save. And we'll end there, and I thank you for your attention.